My name's Clarence Norman Thompson, and I live at a little cottage out at Nanama, Cottage 6, 1-bedroom home. I've got cirrhosis of the liver. I had hepatitis, but that's cleared, and I'm on high blood pressure. They've got me on blood pressure tablets.
I've had diabetes for probably about 15 to 12 years. I'm a type 2, so I'm both tablets and insulin. I wasn't taking my tablets. I was getting a lot of being in hospital.
We were brought up to that diabetes was all right, and heart attacks were fine and stuff like that. So I think if you have myself, one person to say like that's not all right, it sort of breaks down that barrier, and people sort of start to wake up.
I've been here in Wellington for the last 5 years. About 19% of the population is Aboriginal, and I think we also have got low socioeconomic community. So we're working closely with the hospital, so we get the discharge summary, especially on flagged patient for integrated care patients, sent to us swiftly, so we don't make medication error, so the patient don't end up in a hospital again.
The hospital's got the access to my health record. By them having that also, it means they can access our patient staff when we're not open on the weekends or in emergencies. We know that they have that data there that they can use.
And it also flags if they're on the integrated care, so the staff can actually see that they're on it and maybe contact WACS to say that this person's in, and one of the workers down there can come up and visit the clients, the Aboriginal clients.
So we meet for case conferencing every month here at WACS, and we have our doctors, our allied health, the hospital staff come, and we bring most patients that enrol in integrated care after they've had a health assessment to identify what needs to be done and how we're going to do it.
So as a dietitian, I'm one of the services that's offered to a lot of integrated care patients. Usually the integrated care workers will help get us involved so that we can help provide a holistic approach to a lot of our patients and really work towards improving their health.
A lot of Aboriginal people don't know, like they just want to take tablets and don't know what they're for. So now I know that I'm on blood pressure tablets, which he wants to keep me down, slowly off my blood pressure tablets, and 6 tablets a day, so which is really good. Where then I was just taking a lot of painkillers, and I didn't want that.
Young Chloe works there, and she lives out of my community, and she said that there was a program going and I'd be good for it. And then, and I'm glad she did, because it's really helped me, and things are starting to change in my life, and my health's starting to come better because I'm in this program and they're helping me out. Where before, if I was go and see a doctor and I'd ask for something, he'd put me on some medication, and I'd go to the hospital and they didn't even know what I was on. And now this new integrated plan, they're linked up together and they know they're on the same page.
I think it's empowering our clients to be in control of their general health and improve their health.
There is a lot of things that have changed in my life. I'm losing weight, just trying to get back to where I was. It gets harder first before it gets easier, but I can feel my difference.
We're trying to get our 15-year-olds that have early signs of diabetes in our program, and we're trying to educate them how important it is to come to the doctor, not just when you're sick, but just for your regular checkups every few months to make sure your medication's working, making sure they're getting their eyes checked every 12 months, all that sort of stuff, instead of leaving it until we've got problems.
Got a transport program going, and if you've got no car, no licence, they can pick you up and drop you off and take you to your doctor's appointments in other towns. So and I'm glad that comes under that plan.
I am working with the girls, and like I say, they work with me, so, and when I know that I get sick, I come to them first.
We know our town, we know our services, and we know what we can help our patients with and, what they need. And they help us, and we want them to have that input too.
It's a great story, isn't it? So I'd like to thank Norman for the acknowledgement to country at the start of the day, but also recognise there's a lot of Aboriginal people here today from other Aboriginal nations, and the power of telling a story from Wiradjuri country on the Eora Nation. So, like Wellington, we've got 9 other sites around Western New South Wales that have taken years in building relationships, and a bit of our story is it can take years to build a relationship but minutes to fracture it. And integrated care for me really is about building relationships and the change that has to go along with that. And you heard from Vahid and Walter a minute ago some of the challenges in that. For me, integrated care is about a whole of a system strategy. It's not just about chronic disease. Now, we've got some fantastic first wave sites, and Cara, Minister, the Plum Jam story, through to Wellington, Cobar and some of our outback country and a number of other sites. We've now moved on to some second wave sites, and one of our real focuses is the first 2,000 days of life. So some of the genetic story we heard this morning, that the care that's provided for a mum and the family from the minute they get pregnant through to the time that the child goes to school is the most informative time in the whole of a person's life. And quite often in country towns, that care is fractured, even though there's a small country town. So 2 of our towns, both Walgett and Coonamble, they're about 2,000 to 3,000 population towns, that they both make a number of records, that they're in the bottom 10% of the most social disadvantaged communities in the whole of the country. In terms of the Aboriginal population, they're both over 30%. More than 60% of the children born in those towns are Aboriginal. More than 30% of the mums smoke while they're pregnant. In the last 6 years, there's been a growth of 20% every 3 years of the highly vulnerable kids, and so these towns are deteriorating quite quickly with the fractured service network. These towns are also in the middle of some of the richest farming country in the whole of Australia. So our challenge is to bring together all the providers in those towns, wrap around a service network for that first 2,000 days of life of everything that should happen in a best practice environment. Now, a lot of that can't be delivered in those towns, so the telehealth network is going to be critical for that. So back to that relationship story. Relationships will take years to build but can be fractured in a minute. That they can be fractured by one little word, one little action that might be so innocent, but they can destroy those years of experience. And so I'd leave you with that thought. Now I'd like to introduce Lisa Altman, who's the next speaker.
But and while Liza's coming up, thanks very much. I just come on up, Liza. Erin Miller, from who's project manager of the Healthy Homes and Neighbourhoods project in Sydney Local Health District. Erin, just talk a little bit about what you're doing that might be different, taking a social determinants approach.
Yes,
Hi.
Thank you. So,
do you want to stand up so people can see you? Sure. That's great, thanks.
So Healthy Homes and Neighbourhoods is Sydney Local Health Districts, or one of Sydney Local Health Districts' integrated care initiatives. And like you said, we're taking a social determinants approach. And our focus is on the whole family, so probably quite similar to what you're doing in Walgett and Coonamble. And we're looking at families where the parents or carers have complex health or social care needs which impact on their ability to provide a safe and nurturing environment for their children, and also participate in their community. When we started, from the very beginning, we partnered with services from the district that meet adult health needs, like drug health services, mental health, child and family services, as well as family and community services, the community services part of that, and also housing, and a host of NGOs working in the area. So we've got Janowy Family Centre, which is a tertiary child protection centre, Family Referral Service, SDN, who provide the Brighter Futures program in Sydney LHD, and we engage them from the beginning. We see families who have children pre-birth to 17 years. The children might be in the care of the parents, or they might not be, but we'll still take them on. We've got a care coordination component, so we have clinical nurse consultants and social workers leading that. And they will do an assessment with the family to figure out what's going on for this family and what's stopping them from engaging with services, and what's going to contribute long term to transgenerational disadvantage and family disadvantage. They'll talk to the family and figure out what that is. It might be a housing need, it might be financial, it might be that the family can't afford to get to the hospital, like they can't afford parking at the hospital, they might have mould in their home, there might be squalor, and then we'll work with our partners to address those issues so that then they can connect into the health system and stay within health. We also have 2 place-based components, so we did some geospatial mapping across the district to find areas of family disadvantage, one being in Redfern Waterloo and another one in Riverwood, and we've got workers co-located in those locations, and what we're finding is putting staff from legal aid, housing, health, drug health services, mental health together in the same room is just enhancing that professional knowledge and trust, knowledge transfer, and they're working together beautifully, and the community is now trusting all of us and coming to us really early on, which is fantastic.
Thanks, Erin. And an important thing here is, and I'm sure Scott's doing it, but we haven't been explicit about it, is that place-based planning at a local level really can make a huge difference to bringing the diverse parts of the system together, regardless of what might happen in Macquarie Street. So thank you very much, Erin. And it's a good lead into you, Liza. Thank you very much.
Hi, I'm Liza Altman. I'm the Integrated Care Manager for the Sydney Children's Hospitals Network. We're working in partnership with the PHNs and local health districts in Murrumbidgee, Western Sydney and South Eastern Sydney, and also consumer organisations representing asthma and allergy. So for the Sydney Children's Hospitals Network, Integrated Care is about building partnerships to support the children in our care, and those partnerships we're building with local hospitals, community health, allied health and general practice. It's focused on the systems change that we need to implement and sustain an integrated model of care across all health services. We start all of our meetings with a patient story, and a recent example from Western Sydney is a really good illustration of the challenges that families of children with very chronic and complex conditions face. So little Abdul went home from the NICU at the Children's Hospital at Westmead at 3 weeks of age with a discharge letter that ran to several pages. It had 18 separate appointments with different teams within the Children's Hospital and a little note on the bottom that said, please find a GP and a paediatrician who can help care for such a complex condition. His mother has got limited English and no family support, and the discharge nurse was really worried about the family's ability to care for Abdul in the community. So how does integrated care help Abdul and his family? We know from the literature and from our own consultations that a thorough knowledge of the child on the part of service providers is really important to parents, and a continuity of personal relationships and communications. And we find the difficulty of communicating across a fragmented health system can be what keeps families coming back to the tertiary children's hospitals and disengaging from local health services. We've therefore focused on partner and patient co-design in developing an integrated model of care, looking at the child as a whole in the context of their family and their environment, instead of that narrow focus on the body part or the system that needs treatment. We want to know, what does the system need to do to support these families caring for children with complex and chronic conditions? And using the language of our families, how do we help them feel safe outside of the children's hospital? And how do we help GPs, paediatricians and other local clinicians feel safe and supported in their care roles for these children? It's become evident that we need to build trust and respect into all our communications and develop artificial professional networks, if you like, across New South Wales, so it doesn't matter who you know or where you trained if you need help in caring for a child. So we've been using a quality improvement framework, and I think that it picks up on Walter's point earlier about incremental change. So we run our integrated project streams through a quality improvement framework. We treat each referral of a child as an opportunity to test and refine the model of care using plan, do, study, act cycles. In our project teams, we have GPs, community and allied health, nurses, paediatricians and subspecialists joined together each week to discuss the referrals and investigate the system challenges that are preventing integrated care for that child. Each month, a larger group, including representatives from the PHN, the LHD and the Sydney Kids Network, agree the system change needed to overcome the challenges and the responsibility for its resolution. The discussions are frequently open and challenging, but we've found that focusing on the story of the child helps everyone to put their agendas aside and really concentrate on the system issues. And through this, we've achieved agreement on referral pathways, common care plans, consistent consumables pricing, and many more, from tertiary right through to primary care. So what are we doing differently? Well, one of the key challenges facing families is there are often many different clinical teams involved, and as I said before, each focuses on their specific part of the body, and nobody's taking that global view of the child and the family. And extremely complex children and families get really lost in that system. So for these children, a care coordinator helps to build a circle of coordination with the child at the centre and a family, community and hospital lead who facilitate care in their setting. So the inclusion of the community lead in the care team and ensuring engagement with a committed GP and local health services really helps provide families with a support system that they trust. And this is reinforced through the shared care plan, which guides the family as to where they can safely and appropriately use local health services. When we asked the mother of young Levi, who was discharged home on CPAP and a feeding tube, what she would do if she was given a magic wand, she said everybody would have access to an app or something, which means everyone had the same information. And she said, this is the folder that I made for Levi. In it are his medical reports, what to do if the tube falls out, a manual on Levi, appointments list, information sheet and medication list. So if something happens to me, you can pick up the folder and know exactly what's happening with Levi and how to care for him. And most of our families have a folder like that. It's stuffed with every piece of information that they've ever received from every agency who's involved in helping care for their child. And we want to help them leave that folder at home and have trust that the knowledge and the communication goes with them. So we're working with them to build a communication and information tool that supports them as they navigate through the health system. Importantly, it's being co-designed in partnership with families, so it reflects what they need to care for their child in their interactions with health services, education, NGOs and more. It'll house all the information that matters to families about their child's care via a smartphone, tablet or the web. And they'll have access to and control of their health information. From the care plan developed by the care coordinators, maybe an NDIS care plan, hospital appointments, treating teams, contact information. But really importantly, it's not just about what we push out to them, it's how they choose to use it. They might want to take photos or videos of their child to track progress over time. They might want to upload the community nursing plan. They get to decide what information they share and with whom. So we're also investing in health pathways to provide clinical and referral pathways to GPs so they can to help them assess, refer and manage paediatric conditions. And developing those pathways means working in partnership with the PHN and the LHD and provides an opportunity for redesign where the current pathway is broken. And because we're trying to improve the equity of access to services, whether for the child from far west New South Wales who needs regular review from 5 different teams at the Children's Hospital at Westmead, or the child who lives 2 kilometres away from Randwick, is on oxygen and in a wheelchair and the family has no access to a car, we're implementing telehealth, web-based video conferencing for all teams in the network to facilitate routine follow-ups and outreach clinics. So, what have we achieved? Importantly, we're connecting families with GPs who have an interest in caring for these children. We're building capacity in the system. And we're keeping children at home with their families, not on the road to see us. We've saved an estimated 36,500 kilometres in family travel in just 1 year. Little Indigo, who's a 9-year-old girl from Canberra, used to drive up to Sydney with her mum every month for an infusion for juvenile arthritis. That meant a day off school for her, a day off work for her mother, and if we'd scheduled their infusion in the afternoon, an overnight stay and another day. And because travelling in a car 3 hours each way was really debilitating for Indigo, another 2 days off school to recover and 2 days off work for her mum. So the care coordinator worked with her local hospital in Canberra to transfer her infusions there, and now she misses half an hour of school every month. So finally, what does this mean for Abdul and his family? So the NICU discharge nurse referred Abdul's family to the care coordination service. The care coordinator sat down with the family and an interpreter and discussed their challenges in caring for Abdul and what they were going to need to support him. The care coordinator worked with a GP liaison nurse from the Western Sydney LHD to link the family to an Arabic-speaking GP, and the GP liaison nurse also helped them to fill in the application for in-home nursing. A care plan was developed with the GP, paediatrician and the hospital teams that outlines the different responsibilities for each clinician, and it provided the family with a day-to-day, week-to-week, month-to-month guide to caring for Abdul. So the care coordinator became their central point of contact within our hospital. And the family now texts in with a pre-programmed text in English when they're worried about Abdul. The care coordinator calls back using the telephone translation service, and they discuss what's the best avenue of care for Abdul, whether that's their GP, their local hospital, or through one of our ambulatory services at the Children's Hospital at Westmead. It's helped to keep Abdul safe at home and supported in his local community. Thank you.
Thanks very much. So, really interesting session there across New South Wales and across populations. To close this session, I re-invite Elizabeth Koff.
Excellent presentations, consistent themes in them all. As reinforced front and centre, integrated care is not just about chronic disease, and I think that's very important for us to remember. I had a nice theme going that I thought there were 5 C words that we could summarise the presentation: connect, coordinate, build capacity, capability, and change management. It was going swimmingly well with my 5 C words until relationships and trust came, which came through consistently on all of them. So I think they all exemplify the excellent work that's being undertaken in integrated care. I would encourage anyone to write on the graffiti wall outside and text anything in response to those presentations, and lunch is served. Thank you.